It's a pleasure to be with you. The title of this talk is Leadership and Management, Basic Budgeting Concepts. There are no disclosures for this presentation. Objectives include define budgeting and discuss budgeting attributes for organizations, briefly review the difference between a strategic and operational plan and where budgeting fits in the overall strategic planning process, review the 4 basic budget rules, review the benefits of effective budgeting, discuss the 5 types of budgets, emphasize the importance of accurate program budgets as an essential base for organization-wide budgets, review the role of the Chief Executive Officer and Chief Financial Officer in the budget process, discuss the 4 major strategies for organization-wide budgeting, and review the basic funding sources for public health. Much of the material for this talk comes from the book, The Budget Building Book for Nonprofits, a step-by-step guide for managers and boards, by Murray Dropkin and Bill Latouche. There are very few resources available providing basic budgeting guidance for public health professionals. This book was written to provide useful budgeting information for those with no financial background. For this session, we will be covering some basic concepts from Part 1 of this text, titled Understanding Budgeting Basics. Part 2 provides step-by-step guidelines to develop a budget, and Part 3 provides additional budgeting resources, including a variety of helpful forms. Though this book is written primarily for nonprofit organizations, the budgeting concepts covered also apply to any organization, both large and small. This would be an excellent book for any public health leader's library. Budgeting is a key base for an organization's operational plan. Utilizing a dynamic, strategic process is critical for organization effectiveness. Through that process, organizations commonly develop a strategic plan and an operation plan. The operation plan is also often called a strategic management plan. The strategic plan defines the mission, central challenge, strategic priorities, and SMART goals and objectives for the organization. The operation plan defines a detailed management plan to achieve those strategic goals and objectives. A major part of that operation plan is the budget. Strategic planning is covered in more detail in other sessions of the North Dakota Public Health Training Network. A simple definition for budget is a plan for getting and spending money to reach specific goals by a certain time. This slide lists some key attributes of good budgets. A good budget represents well thought out ideas for future actions. A budget is absolutely essential to achieve specific organization goals. A good budget should accomplish operational goals within a specific time period as mentioned in the definition. A good budget is informed by past experiences and utilizes current information and future assumptions. Dropkin and Latouche list 4 basic rules about budgets and plans. Rule 1. A budget is a plan for spending money to reach specific goals by a certain time, as previously mentioned, emphasizing that budgets are generally rigidly time-bound based on the organization's fiscal period. For the North Dakota Department of Health, the budget period is 2 years, since the legislature meets biennially. In Minnesota, The health department budget period is for 1 year. For highly dynamic organizations and situations, a budget period could be a few months or even weeks. The main point is that budget periods must be firmly defined or accurate budgeting is impossible. Rule 2. Any budget plan is only as good as the time, effort, and information people put into it. Good budget practices should foster collaboration and exchange of information among the budget team participants. In other words, good budgets should be appropriately inclusive. Rule 3. No budget or plan is perfect, since none of us can totally predict the future. Rule 4. In order to reach goals, all budgets and plans must be monitored and changed as time goes on. Budgeting is not a one-time event, but an ongoing process of data gathering, analysis, revising projections and assumptions, and informing alternative solutions to problems. As implied in Rules 3 and 4, budget plans, like any other planning process for the future, must be flexible to adapt to miscalculations, less than accurate predictions, and environmental changes in which organizations operate. Effective budgeting is directly associated with the viability, solvency, sustainability, and overall health of an organization. A clear, effective, well-thought-out budget helps an organization adjust plans, influence policies, spend money effectively, and reach the SMART goals of the strategic plan, where S stands for specific, M for measurable, A for achievable, R for reasonable, and T for time-bound. Effective budgeting also helps organizations receive clean audit findings and avoid disallowed costs or cost overruns. A good budget also lets everyone in the organization clearly understand the work or tasks needed to obtain organization goals, the resources required and available to accomplish that work, defines clear timelines, and who's responsible and accountable to meet those goals and timelines. It also provides financial measures for operational effectiveness and organizational fiscal health. Dropkin and Latouche summarize that good budgeting is thoughtful and deliberate, inclusive, and an ongoing process that leads to greater financial stability, operational effectiveness and efficiency, and responsiveness to organizational needs and priorities. I would like to emphasize that budgeting is an ongoing dynamic process operating within a firmly fixed time frame. There are generally 5 types of budgets: total organizational-wide operation budgets, operating budgets for individual programs, units, or activities, capital budgets, cash flow budgets, and opportunity budgets. The total organizational operations budget commonly includes all of these other budgets. Let's first consider organization-wide and individual program budgets for a few minutes. An organization-wide budget is necessary where organizations have multiple programs. This is extremely common even in small public health units. An organizational budget is comprehensive, covering all activities, units, programs, divisions, and sections of the organization. An organization-wide budget covers everything, including all employee costs, including salaries, benefits, estimated travel costs, continuing education costs, etc., consultants, total program expenses, all services provided, facility expenditures, etc. Developing an organizational budget is commonly a pyramidal process, as illustrated on this slide. It starts with program budgets that then are aggregated to form division budgets. If program budgets are poorly developed, the whole organizational budget will be a disaster. Be sure the lower layer of the pyramidal budget is accurate, since it impacts all the other upper layers. Division budgets then result in section budgets. Section budgets then informs the whole organization-wide budget. As you might expect, the budget process takes significant time and must be well organized and managed. The leader's role is to do that. Organize and manage the whole budget process and includes defining the budget cycle. During my time in the state health department, we started our budget cycle in June, 6 months prior to the start of the legislative session. A main point: give enough time for organization personnel to do their budget planning work through all levels of the organization. The leader must also clearly assign responsibilities and accountabilities for budgeting, making sure that all aspects of budget planning are covered by someone. Another key leader role is to define a budget calendar, setting out clear and reasonable timelines and deadlines for managers, program directors, and the chief financial officer if the organization has one. The leader also must clearly outline organization policies that describe the budget framework, like defining the standard rate of inflation to be used when calculating the budget, etc. Resource E and B in the text provides samples of an organization-wide and program budgets. Dropkin and Latouche describe 4 basic strategies for developing organization-wide operating budgets. 1. Based on the organization's strategic goals. 2. Based on revenue and expense targets identified by leadership to guide draft program budgets. 3. Request draft program budgets that demonstrate program priorities for increases, decreases, and fiscally neutral budgets. And 4. Zero-based budgeting. For strategy 1, the draft budget process works off the current organization's strategic goals as a base. If effective strategic planning has been done and is critically reviewed annually as strongly suggested, then those goals should be current and reasonable upon which draft program budgets can be developed. Those goals need to be SMART, as previously discussed, providing enough specificity for program leadership and measurability for fiscal monitoring. Those annual strategic reviews and resultant goals should also be informed by the chief financial officers and leadership's projected revenues, expenditures, and internal and external environmental forecasts. These strategic goals can be developed through an authoritarian or more democratic process dependent on the leadership style of the organization. Democratic approaches foster more personnel ownership and commitment to those strategic goals. Strategy 2 is where upper-level management sets revenue and expense targets for programs, and programs are expected to develop budgets to meet those targets. This is a more authoritarian strategy based on leadership expectations versus program-level ideas. Strategy 3 is where leadership requests draft budgets from programs and asks them to prioritize increases, decreases, or neutral budgets. This practically is a three-step process. In step 1, leadership asks programs to develop 3 draft budgets based on a range of percent variations assigned by leadership. For example, a few years ago, based on direction from the governor's office, our health department was asked to develop 3 organization-wide budgets, one 5% higher, one 5% lower, and a fiscally neutral option. As leadership, we pass that direction on to our programs, divisions, and sections. Step 2 in this process is when programs develop those draft budgets along with narratives describing the impact of each option. Step 3 relates to leadership then adjusting those budgets for all programs to ultimately determine and fit the organization-wide budget targets and meet the organization's strategic and operational goals and objectives. Strategy 4 is zero-based budgeting. Zero-based budgeting is an intensive reevaluation of each program, activity, and position in an organization or department to determine if it should be continued, and if so, how. This strategy requires that management justify the existence of every facet of the organization during the budgeting cycle. There are no built-in items or assumptions of continuation for any activity or program in zero-based budgeting. Zero-based budgeting asks the question, if this activity or program would not be here today, would we start it? There are 4 basic zero-based budgeting questions to be answered by all facets of an organization in a zero-based budgeting process, including 1. Should the program, activity, or position be continued, or would other activities be more important or appropriate? 2. If the program, activity, or position is justified, should it continue operating in the same manner or should it be modified? 3. If modified, how will it be modified, when, and by whom? 4. How much should the organization spend on the program, activity, or position under consideration? Zero-based budgeting steps include 1. For each program, activity, and position of an organization, identify the major functions performed. 2. Answer the 4 basic zero-based budgeting questions from the previous slide for each program, activity, and position. 3. Create alternatives or options based on answers to the 4 basic questions. 4. Project revenues and expenditures related to each option or alternative. Leadership then has 3 management decision options to choose from based on these 4 zero-based budgeting steps. 1. Abandon the program, activity, or position. 2. Change, strengthen, simplify, redirect, reorganize, or outsource the program, activity, or position. 3. Make no changes in the activity, program, or position. During my tenure in the health department, we did discontinue, change, and outsource several programs, activities, and positions utilizing a modified zero-based budgeting process like this. Zero-based budgeting, if done well, can improve efficiency, effectiveness, and productivity, and help organizations expand horizons and look for new opportunities. Yet zero-based budgeting is not a panacea. Problems with this strategy include zero-based budgeting success is dependent on accurate revenue and expenditure data that is not always available. As you can imagine, it is threatening to organization personnel when the value of their existence in the organization is seriously questioned. This process can result in significant morale problems in the organization. Zero-based budgeting is also very time-consuming. So we briefly covered total organizational-wide and program-level budgets. Let's now consider capital, cash flow, and opportunity budgets. Capital budgets relate to capital projects, like large one-time non-recurring expenditures. Capital budgets generally can be divided into two categories. One, capital improvement projects such as the construction, purchase, or the renovation of a building. Or two, capital equipment projects such as the purchase of expensive new equipment. Capital improvement or equipment projects generally have a useful life of at least 1 year. Resource B in the text provides an example of a capital budget. Cash flow budgets are essential for the day-to-day and overall fiscal health of organizations. Failure to manage cash flow properly can result in severe operational problems. Cash flow is the difference between cash coming in from the various revenue sources and the cash going out or expenditures of the organization, and can fall into three situations. Positive cash flow are times when more revenue is coming in versus expenditures during a specified period of time. Neutral cash flow is when revenue and expenditures are equal, and negative cash flow occurs during times when expenditures are greater than revenues. Therefore, an effective cash flow budget requires not only accurate estimations of the income or revenues and expenditures of the organization, but also accurate estimates of the timing of revenue and expenditure transactions. Problems arise when income lags behind expenditures. This is not uncommon for many organizations, since they're often reimbursed by funding sources like granting agencies or organizations for services rendered, often long after expenditures occur. Appropriate planning for adequate cash reserves to cover these negative cash flow periods is essential to address during the cash flow planning process. Opportunity budgets were described by Drucker in 1980. Opportunity budgets plan for and examine opportunities for organizations to do something new and different, like expanding the organization's mission or improving the organization's operations. Opportunity budgets would relate to boundary spanning work and concepts, advancing into new horizons, that are discussed in detail in other sessions of the North Dakota Public Health Training Network. Opportunity budgets apply when budget surpluses materialize. Surpluses are not a common occurrence for most public health departments. Opportunity plans and budgets are developed in advance of a surplus and are ready to be implemented when the opportunity arises. An effective opportunity budget depends on two things: sound budgeting practices and clear, efficient, and realistic strategic planning, including well-conceived goals and objectives. Drucker points out that actively researching and looking for opportunities that your organization can economically support is one of the most effective growth-promoting tools. So even though surpluses may be uncommon, developing an opportunity budget is important for health departments for those times when funding unexpectedly materializes. I've seen that happen with new grant requests for proposals that had short turnaround times, and occasionally during legislative sessions when a political leader presents a bill that unexpectedly opens a new possibility for public health. Having opportunity plans and budgets in place favorably positions health departments to rapidly respond to those opportunities. As previously mentioned, the organization's chief executive officer or leader's role is to organize and manage the whole budget process, including define the budget cycle, clearly assign responsibilities and accountabilities for budgeting, making sure that all aspects of the budgeting plan are covered by someone, define a budget calendar, and outline budget policies. In many organizations, the CEO will hand many budgeting tasks to a chief financial officer or CFO. Being able to hire a CFO was a requirement for me to accept the state health officer position in North Dakota in 2001. Up until that time, the state health officer was essentially filling both the CEO and CFO roles. Unfortunately, many of them had little budgeting or fiscal management experience, competencies, or skills to run a large, complex organization of 300 plus employees. The CFO, particularly in public health organizations, is a challenging full-time job. My CFO, or Deputy State Health Officer, was a certified accountant with over 20 years of government accounting experience and had a master's degree in public administration, a perfect fit for that position. This allowed me to focus mainly on the department's strategic issues or the strategic plan, and my deputy primarily on the operational strategic plan and budget. I want to emphasize that this was not a rigid division of labor. There was significant overlap dependent on the competencies and skills needed to address issues within the department. Personally, I feel that one major reason I was able to stay in the state health officer position for 15 years was due to that initial requirement of hiring a well-qualified CFO. This slide lists the common roles of a CFO like that of my deputy. For the budgeting process, a CFO has major responsibilities, including create a budget calendar and monitor timelines and deadlines. Communicate budgeting policies and procedures to section chiefs, division directors, and program leadership. Establish formats for the budget process, including design of budget format documents. Develop revenue and expense forecasts based on a variety of internal and external data and information, including the ever-changing political climate at the federal, state, and local levels. Coordinate and set revenue and expense targets for the programs, divisions, sections, and organization-wide levels of the budget pyramid. Evaluate draft budgets for accuracy, reasonableness, fitting appropriate guidelines, and within anticipated or forecast resources. Present and discuss the draft budgets and their rationale with the CEO and other members of the organization's leadership team, moving the process toward final budget adjustments. Make recommendations for reducing, increasing, or reallocating resources to create a final organization-wide budget. Prepare the final budget document and help present this budget document to the board, governing authority, or legislative body for approval. Very seldom is a budget passed by the legislative body as written. The CFO, along with department leadership, must continually address and discuss how proposed changes, amendments, or other public health-related bills will impact the department, the budget, and the services it provides with various committees, stakeholders, and the governing authority. At the end of the legislative session, the CFO and department leadership must pull all of these changes into a final functional budget for the fiscal cycle. This is not always easy, especially when a group like the legislative body passes unfunded mandates. I hope you realize that the CFO, along with department leadership, are extremely busy during the legislative process, monitoring all bills that may impact the organization's budget, preparing testimony, and providing appropriate information to key individuals and groups. After the legislative process, the CFO is responsible for implementing the budget, monitoring and analyzing the organization's revenues and expenditures, providing reports and potential fiscal solutions for emerging financial issues and problems, and overseeing corrective actions. I hope I've been able to demonstrate how important a CFO is in managing an organization's budget, particularly for large public health organizations or departments. The next several slides will briefly discuss public health funding sources, including the federal government through various programs and grants and state general funds, local general funds, grants from nonprofit organizations like the Robert Wood Johnson Foundation, Bush Foundation, American Heart Association, American Lung Association, etc., and special funds like fees, fines, tobacco, settlement dollars, etc., for state, local, and tribal public health programs as listed. Funding for public health varies based on the programs provided by a public health department and the roles public health plays in meeting the needs of populations within their jurisdictions. Let's start by considering funding sources for state health departments. All state health departments are significantly funded by the Department of Health and Human Services, DHHS, Centers for Disease Control and Prevention. The scope of the state health departments varies from state to state. In some states, the state health department administers the Medicaid program and receives funding from the DHHS's Center for Medicare and Medicaid Services, CMS. Medicaid operations and funding tends to dwarf population-based primary care prevention programs in many of those states, becoming a major focus of the Department of Health. From my perspective, it is better to separate the payer agency that covers Medicaid from the agency providing population-based health strategies, since payer funding can influence and drive department strategy in those situations versus the needs of the population. Tension between funding and population health strategy is healthy. Some state departments of health oversee environmental programs and therefore receive significant funding from the Environmental Protection Agency, EPA. The main point is that state public health is heavily funded by the DHHS, no matter whether they administer a Medicaid program or not. This slide lists some of the basic state public health roles, including screening and treatment of key diseases like tuberculosis, sexually transmitted diseases, HIV/AIDS, newborn screening, etc., supported by numerous DHHS CDC grants, and often delivered through contractual services to local public health or other provider groups. In some states, the state health department actually runs clinical services. Other roles for state public health includes providing technical assistance and training of local public health units and other stakeholders, including emergency responders, hospitals, etc. Laboratory services for contagious diseases, toxins, bioterrorism agents, etc. Epidemiology and surveillance systems, and as previously mentioned, facilitation of collaboratives and partnerships. Public health is often viewed as a neutral party and therefore well positioned to facilitate collaborative efforts. Generally, state public health, like the federal public health system, is primarily to support local public health and other stakeholders who provide many, if not most, public health services in states. This was the organizational chart when I was state health officer for North Dakota, providing insight into the roles of the department that informed our budget. We had 6 sections, including administrative support that included human resources, accounting, public information, education technology, informatics technology, and vital records. My deputy state health officer was the director of the administrative section. The accounting division within that section oversaw the budgeting program for the department. Community health included several programs associated with risk factors and wellness. Emergency Preparedness and Response, EPR, contained our preparedness and disaster response programs and oversaw the state's emergency medical system, including ambulances and the state's trauma system. EPR also organized and oversaw the health department's incident command process that was utilized to coordinate complex responses across department sections and with external stakeholders. We often had incident command running for up to 6 months per year. Health Resources was the section that oversaw health facility regulations. Medical Services gave administrative oversight to disease control issues and the state's forensic program. Environmental Health had programs in air and water quality, laboratory services, municipal facilities like water treatment plants, and waste management. This type of organization structure is not unusual for state health departments. This pie chart represents the North Dakota Department of Health's budget from 2017 to 2019 and is similar to many other states. The total budget was $197 million, and funding sources included 60% federal, the main source, 23% state general funds, and 17% special funds from fees, fines, tobacco settlement dollars, etc. This is an example of department spending per section for the 2017 to 2019 biennium. The administrative section was allotted 10% of the budget, health resources 5%, medical services 9%, community health 34%, emergency preparedness and response 11%, and the environmental section 27%. Community health and the environmental section covered 61% of the budget, or nearly $120 million per biennium. Let's now consider local public health funding sources for a few minutes. Local public health generally provides more direct service delivery versus the state, yet this varies greatly from state to state and also relates to how state and local health is organized: centralized, decentralized, mixed, or shared public health structures. A decentralized public health system means that the local public health department is run by local governments. Centralized means that local public health is part of the state health department. Mixed is where there are some local departments run by the state and others by local governments, and shared, where all local health departments are governed by both state and local stakeholders through a joint board. As you might expect, how public health is organized in a state significantly influences public health budgets and how they're funded. NACHO, the National Association of City and County Health Officials, lists the 10 most frequent activities and services provided by local public health units across the United States. 92% of local public health units provide adult and child immunizations and communicable disease services. 85% tuberculosis screenings. 78% food service inspections. 77% environmental health surveillance. 76% food safety education. 75% tuberculosis treatment. 74% school and daycare inspections, and 71% population-based nutrition services like WIC. This slide shows the general funding sources for local public health aggregated nationally. 26% of local public health funding comes from local sources, followed by 21% from the state. State and local funding therefore provides 47% of local public health budgets, with 53% coming from other sources, including 14% federal pass-through dollars administered by the state, 7% from fees, and 13% from the Medicaid program. This 13% would only apply to the states that administer the Medicaid program. There are a few key acronyms on this graph, including FER, which stands for Public Health Emergency Response Funds, and ERA, the American Recovery and Reinvestment Act of 2009, passed to help recover from the Great Recession of 2008. This is an example of a local public health budget from 2017. This is from the Southwest District Health Unit with offices in Dickinson, North Dakota. 44% of their budget comes from local funding, property taxes, and mill levies, compared with 26% from the National NACHO study. 28% comes from federal grants, essentially pass-through dollars from the State Department of Health versus 14% nationally. State aid that comes from the state's general fund makes up only 8% of their budget versus 21% nationally. Fees for immunizations, inspections, etc. provide 9% of the budget versus 7% nationally. Other sources include tobacco settlement dollars, 6%, and interest, donations, etc., 5.5%. For the Southwest District Health Unit, local and federal funding from the CDC provides 72% of their budget. In summary, good budgeting leads to greater financial stability, operational effectiveness and efficiency, and responsiveness to organizational needs and priorities. The total organizational operations budget commonly includes all program, capital, cash flow, and opportunity budgets. Effective budgeting is associated with the application of the 4 basic budgeting rules. Effective strategic planning and annual reviews of that plan set the goal base for a budgeting cycle. A chief financial officer is critical for the budgeting process of large organizations. An opportunity budget is an effective growth-promoting tool. Public health funding sources vary between state, local, and tribal health departments.